Or the new one. You're talking about the new one? The housing plan.
Yeah, it started last July.
Yeah, the housing plan. I went to, meeting weeks ago, Joe was there.
It's because we all stare at it. Here we go.
Right.
Let's rise for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, I want to welcome everyone to the Health and Human Services meeting of March. You have an agenda in front of you. What is your pleasure? Any discussion? All in favor, please say aye. Aye. Any opposed? All right, you have your February 5th minutes in your packet. All in favor, please say aye. Aye. Any opposed? Brings us to our first round of limited public comment. And since Sarah's probably here in a professional capacity, we will pass along, all right? And that brings us to Sarah, the highlight of our agenda. Come on up. We're all here for you.
Well, I do appreciate that. All right, well, good morning.
Morning.
I was saying, it's a Monday morning, but it's so hard not to feel great and happy when the sun is shining like today. When I was here last in October, we were just entering the new fiscal year, and here we are now almost midway into it, and it already feels like spring here. So during this year, our focus really has continued to be on strengthening our workforce recruitment and our service delivery as a CCBHC. We continue also slowly to make progress on the development of the Crisis Stabilization Center on the Green Lawn campus. And we've worked hard this first half of the fiscal year to complete an organizational strategic plan. So that was passed by our board of directors in February, and we'll be getting it up on our website and distributing it. But for this plan, the focus was really on developing a practical vision for the organization's immediate future. So kind of it's really turning out to be about a 3.5-year plan. There were 2 questions that guided the creation of the plan. And that's how will CMHA CEI adapt in order to deepen and improve the quality of care to meet the evolving mental health needs of the community? And what key outcomes must CMHA CEI accomplish to realize its practical vision for 2027? And as a result of those guiding questions, there were 5 focus areas determined that the plan focuses on. So they are optimize and adapt our services and how we deliver them, rethink our systems, processes, and communications to achieve organizational excellence, build our workforce capacity, build stronger community support and partnerships, and address social justice, diversity, and disparities along with social determinants of health. So I'm really excited to have this plan approved and underway. It really becomes an important roadmap as we continue our work going forward. I also handed out to you a handout on CCBHC. This was produced by Community Mental Health Association, and it includes data from the original 13 CCBHC sites that were part of the state demonstration project, and really shows the success that those sites are having across the state in meeting the goals of CCBHC. This year, the state expanded that project, added 17 additional sites, so there are now 30 sites. And I did note in the governor's executive budget proposal, they included some funding to expand that further. So I think the hope is that all 46 of the community mental health organizations across the state may become certified community behavioral health clinics to really, in this last 3 years of the demonstration project, really give us a good look at how our public system can be improved overall under this model. So I'm not going to review this handout in detail with you, but you have it, just shows some of the improvements from baseline to where we are in 2023 in the numbers of people served. The state project also has an emphasis on opening the doors to individuals with mild to moderate conditions. That's not a population that was traditionally served in the public system. It's been great, I think, for us to be able to do that because when you're called community mental health, you really should serve the entire community. And in the past, under the structure of the funding for the system, we were limited to serving individuals with serious to severe mental health needs. And now we are serving pretty much all comers around mental health needs. It also shows on the back what CCBHC has done for substance use disorder services. That has been a big area of growth for us under the CCBHC. It covers outpatient treatment and medically assisted treatment. And that has been one of our biggest areas of growth in our service area, has been able to kind of take on the outpatient care outside of the Mid-State Health Network and to manage that on our own. And we've been able to grow that quite a bit. So those are a few things. Just to remind you about CCBHC, we're required to provide 9 services, management, case management, psychiatric rehabilitation, peer support, counselor services, family supports, community-based mental health care for members of the armed force and veterans. So those are all areas we worked hard to build and put into place to be in a position to be part of the state project. We had several years of expansion grants, federal expansion grants, which really helped us to position us well. We became fully certified by the state 2 years ago, and this summer we will be going through the recertification with some updated federal requirements for that certification. I mentioned to you we've been able to expand and open those doors to mild to moderate. We started doing that in March of 2023, really at the same time as the tragic events at MSU. And so we've been able to manage to increase that availability of those services despite some of our workforce capacity issues by being really creative. So we have developed what we call community care services. We have a number of our staff who have traditionally worked in private practices outside of their regular jobs. So we thought, why don't we kind of create that environment in our organization where our staff can work outside of their traditional hours to provide services and earn some extra income as they would in a private practice. So that has worked out really well. We have about 12 of our staff who are working part telehealth, part in person, evening hours, in order to meet the needs of some of those mild to moderate folks and individuals who are on commercial insurances. We've also expanded our traditional kind of outpatient services clinics that we already had up and running as well to meet that need. Oops, wrong pair of glasses, sorry. Okay, that's better. I did want to share with you some of our data from fiscal year 23. So in fiscal year 23, we served 13,159 individuals. That was an overall increase of about 3% from fiscal year '22 and a 12.4 increase from fiscal year '20. So fiscal year '20 was really, as you recall, when the pandemic hit. And you can see that we've regained a kind of a lot of momentum since then and increased our services overall 12.4% since then. In Eaton County, in fiscal year '23, we served 2,187 residents in our counseling services, counseling and support services. And that is actually an increase of 25% from fiscal year '20. Our highest overall increase in population served in fiscal year '23 was seen in outpatient substance use disorder services at a 15.6% increase, and in youth served ages 0 to 17, a 7.2% increase. So we do, of course, we're still studying that prospective payment that comes under CCBHC. It has so far, once the state made adjustments after the first year, it has proven to be a good thing for us, being able to, you carry the risk, but you also are able to carry over dollars that aren't spent, that are earned through that prospective payment. That's what allows us to then continue to serve people who are uninsured, underinsured, or on commercial plans where their services aren't covered by their commercial plan. So I think as long as the state continues to be open and willing to make adjustments for the success under this rate, I think it is a good model that is allowing us to do more than we could in the past. So we certainly hope and will be working towards asking the state to continue the model and that payment system even beyond the state demonstration project. Just to focus on some of the challenges, because as you know, there's always challenges. With the end of the public health emergency, we are going through the redetermination for individuals who now have to annually be redetermined and re-enroll in Medicaid. And while locally in our area, we are still doing okay with that, statewide, what we're seeing is that the projections that the state and the actuaries used to set the rates for the public system this year were much higher than what's actually turning out to be true. So the enrollments are about 10% lower than what they were using in determining the rates. So the state will be taking a look at that in April, now having half of a year under our belt around redetermination, and will make adjustments to those rates as needed. So hopefully they will do that and hold true with what they're saying, but they sound very open to take a look at it. I think it was a very difficult thing to project how it would roll out after so many, going through the pandemic and so many years where people just were able to stay on without having to do those redeterminations. Probably for us, what we're seeing that is a difficult aspect is many people are being redetermined and put on spend downs. And those spend downs under Medicaid mean that people have to spend a large part of their personal income every month before they qualify for Medicaid. So it's literally like they're uninsured for 3 weeks until they meet the spending requirement, and then they're covered by Medicaid, and that happens every month. So some of our folks who are in very high levels of care, we generally, in order to keep them in service, need to use general fund and some of our local dollars and our health millage dollars from Ingham County to meet those spend down requirements. The qualifications for those spend downs have not changed in our state for decades. and really do need to be adjusted to meet income levels and things that are more realistic for today. But so that's an area that we are definitely keeping a close eye on. We continue, of course, to struggle with finding psychiatric hospital placements. That is the kind of one of the things we hope the development of the Crisis Stabilization Unit will help with, not as a replacement for psychiatric hospitalization for those who need it, but as another tool that we might be able to use to divert a psychiatric hospitalization. If we can keep people in our crisis stabilization unit for a few days and start treatment, there will be some folks who we will be able to just then maintain on a high level of service in the community without sending to a psychiatric hospital. So we're looking forward to that. We've made some progress on our struggle to find qualified candidates to fill master's level mental health therapist positions, residential techs, and nursing positions. We've been doing a number of things to work with that. I think I've mentioned to you, we have greatly expanded our internship program. A couple of years ago, we would have about 20 interns a year. Now we have 70 interns. Last year, that proved to be our best pipeline to hiring. So we're looking forward to graduations coming up soon and people graduating who are applying to positions to fill some of our existing gaps. Always great to be able to hire an intern that is already familiar with our organization and some of the systems. We also are still funding our cohort of 9 bachelor's level employees in obtaining their master's degree in the MSU School of Social Work. So they are just finishing up their first year. Most of them, it will be a 3-year process for most of them. We're looking to see how this might be impacted. I don't know if folks have heard about the recent cuts that Michigan State University is making to their social work program due to enrollments. So they will be not offering as many courses and maybe cutting back on their weekend programs and things like that. So hopefully that will not disrupt anything for the individuals that we are putting through that process. But it is disheartening because we are truly in a behavioral health crisis. And I know the state has been working on a plan to fund individuals in obtaining MSW who have a bachelor's of social work degree and funding that, but it just isn't moving quickly enough to save some of these programs at Michigan State. So we also continue to offer a referral payment to our staff for referring individuals who then go on to be hired as a mental health therapist. We also, in terms of the nursing pipeline, this past year, we have hosted a cohort of nursing students in a field placement along with their instructor. They were on site about 6 hours a week, rotating through the different departments and units that have nurses in it, able to work with them to do some hands-on things with those nurses. MSU nursing students loved it. They have not been exposed in this way to the vast variety of psychiatric nursing options, especially in outpatient settings. So it's really exposing them early on to those possibilities, and we hope that will bring a pipeline into psychiatric nursing as well. We've also been trying to work with some of the high school vocational programs that have healthcare tracks to add a behavioral health care component to those kinds of programs. And then, just quickly with Crisis Stabilization Unit, I know I presented on this, I think, in October as well. Just, incremental movement in terms of facility planning. We are getting, I think, closer to being able to do the bonding request to Ingham County for the building. We're getting more true construction costs. There's a development agreement involved that both our board and the Ingham County Commission has to agree to before anything can move forward. So a lot of those details are just taking a lot of time. But hopefully, if it all moves forward, we'll begin renovation sometime this summer. Hopefully, able to stay on track with opening that unit sometime in early 2025, so calendar year 2025. We will keep you posted on that. And then some Eaton County updates. We have put in a lot of focus on getting people in quickly for intakes in our Jolly Road facility, and for kids in Lansing, we're actually doing same-day access to intake appointments. In Eaton County, we tried to do that, and it just was not working out as well at Eaton County Counseling Center, and they're finding giving people an appointment within 1 or 2 days seems to work better, and it's reducing or increasing the show rate for those appointments. So that's good. They are finding increased demand for new child and adult consumers, and they're still short one adult position. The Eaton TIP, Truancy Intervention Project, is up and running under the newer model. So under this, the staff receive the initial referral, they complete the initial engagement with the family, conduct the assessment, and then they do a warm handoff on the case to the appropriate staff at the appropriate level of care. So we're using kind of a broader range of resources that we have in place to serve those truancy cases and sharing resources across the 3 counties. So that seems to be working out pretty well. And then we were able to bring in, after a long time, a psychiatrist to serve the Eaton County Jail. So Dr. Dillon has been providing a few hours a week to the jail, and we hope that will continue to go well. And we are also continuing to work with Barry Eaton District Health Department on their CDC grant. We will be providing under subcontract peer recovery coach to the county as well. And lastly, just want to have you take a look at our upcoming event flyer on April 2nd. It's our community breakfast event at the Lansing Center. I hope that you'll join us. We have Dr. Tanya Bailey speaking on diversity, equity, inclusion. She's a very dynamic, multi-talented speaker who we think can really engage everybody in the broad audience that attends that event. And then, of course, we'll be releasing our annual report from 2023. So that was the bulk of my updates, but I'm happy to answer any questions you might have.
I don't have a question. I just want to make a couple of comments in regards to Sarah's report. The first is I'm not sure that everybody understands the significance of the CCBHC process. In the time I've been on the CEI board, there have been 2 consistent complaints. The first is that there aren't enough beds, hospital beds, for people who truly need them, and there's nothing that CEI can really do about that. The second was that people who have family members or even themselves who are in difficulties go to CEI for service and get turned away in the past because they were considered mild to moderate situations, which is all well and good in a clinical kind of fashion, except when you have a loved one who is in distress, that's the last thing you want to hear. And the system really was very difficult to navigate to figure out who to go to under those circumstances. CCHBC allows CEI to let those people in through the door now. And I think it will make a much greater impact on the general public, because now there is truly becoming one place where you can go and you can largely get service. And so that's huge. The other thing I want to she touched on it briefly in terms of the finances with the readmissions for Medicaid. I also serve, as I think you all know, on the Mid-State, the PIHP board. At the last meeting, they indicated to us that of the 13 CMHs that make up the Mid-State region, 12 were in financial difficulties last year, and appears will be in some financial distress this year, CEI being the only one that's not. So I think that's something that we really need to congratulate Sarah and her staff, her CFO and her staff, for they're taking very close watch of this. It's a volatile type of situation because of the pandemic. Nobody's quite sure what the impact is going to be. And so far, they're doing a fine job. She indicated that there were over 13,000 people who were seen. When I first went on the board, it was about 7,500. And I remember talking to the gentleman who ran CEI at that time, and he told me that probably in the Tri-County area at that point in time, there were probably something close to 25,000 people who, for various reasons, could use some assistance. Now that, I'm sure, included the mild to moderate, included people with substance abuse problems. The point I'm making is that over the period of time that I've been on that board, we've always tried to push to find a way to open the doors to more and more people to be able to come in and receive services. And that is still an ongoing ambition of all of the people, and Sarah, her staff, and the board. And then finally, she didn't really touch on the threats. There is, for the last 12, 13 years, there always seems to be some kind of threat to the public system. There is one kind of laying in the weeds out of the Capitol. It's called conflict-free, and right now, if you go to CEI, you're assessed by CEI, and you're, as she talked about, you're then placed in the appropriate services. Conflict-free is a theory that comes theoretically out of the federal government, in which, because of a concern for fraud, you want the assessor, the person who's assessing the level of services, to be different, or the organization to be different from the organization that is actually doing the services. The idea being, of course, that if I do both, I can pad well, frankly, that runs counter to the CCHBC model, but it also ignores the fact that we have a public system. Their Medicaid money it comes to them regardless. It comes to them regardless of what services they provide the individuals who are eligible. It's an unnecessary potential problem. The state has indicated for the last several months that they were going to make some changes. They haven't really indicated what those changes are going to be. I note that I was told last that they would make an announcement in January and February. This is March. Nothing's been done yet, but it's out there. What it would do would be fundamentally change the public system again to really make CEI ultimately a provider only and be no different than any other provider, which would change the nature of that organization and significantly change the number of services offered and the number of people employed. My belief is that there are probably well-meaning bureaucrats in Lansing who have, at the end of the day, absolutely no idea how the system presently works. And so we see some of these proposals which sound relatively good or fair or whatever in the abstract, but in reality would fundamentally change the system because they don't understand it, which is too bad. And so with that, I think Jeannie has a question or a comment, and thank you for your time.
Thanks, Joe.
Thank you, Joe. Okay, so we're now more able to do the commercial insurance people. What I run into is like, people who have these high co-pays, you know what I mean? So are you able to work with them on their high co-pays? I mean, they might be in a situation where, for a couple weeks or so, you know, they should even be talking to somebody 2 times a week just to get them through something. And then they'll say, well, but I can't afford the copay because my, you know, whatever, I lost my insurance, or it's only good till the end of the month, or, I mean, I hear all sorts of stuff.
Yes, we are working on kind of the script of how to help with that. That is an area where we have not completely turned on all our billing processes. We're still working on the system and the structure and education for our staff. So really what we plan on stressing to folks in that situation is that as the public safety net provider, we don't end services for people if they have an inability to pay. So the last thing we want to do is disrupt services. Yes, they will probably still get a bill because legally we're required to bill, but we're not chasing people for that payment when they indicate they have an inability to pay. We can negotiate something that's more reasonable. We can do payment plans, but we will never end services prematurely for people who have need.
There's a big difference. I mean, like, if they get laid off or something on February 2nd and their insurance is good, you know, that was like a crisis deal.
Yeah, and there's, so we've always had kind of what's called ability to pay. When people come in, they share financial information, and what gets calculated is an amount based on their income and dependence that they would never be billed more than. And if folks are on Medicaid, that ability to pay is always zero. So yes, that's where we're starting to see. We have some folks who have the means. It looks like they have the means to pay, a higher ability to pay, but that doesn't mean they always are able to do that on a regular basis. But that's kind of the new area of growth for us, is navigating that.
And then my second question is, you know, Grand Ledge is in the process right now of setting up that health clinic. So are you working in any capacity with the people who are going to be providing services if you run across these youth that, you know, come in for a health situation and then find out, oh man, everything's falling apart at home? So they
Yeah.
can do some services.
Yeah, so we are staying abreast on those developments. Eaton Risa is really taking the lead on the mental health pieces. And then we would, of course, work out referral processes to make sure that people in need that couldn't be fulfilled in that clinic are able to access our services.
Okay, very good. Because they actually have a nice area of the building that they're setting up in.
Very exciting.
I know.
Long time coming.
Long time coming. Thank you.
Yeah, go ahead, Mark.
Thank you, Mr. Chair. I just want to follow up on my fellow commissioners here who are much more knowledgeable and eloquent than me. Sarah, we have people that ask for help. You basically give everybody that asks for help the help they need. Okay, what is your best guess of the people out there that need help, but for the list of reasons that we've gone over before, they don't come to you and even ask?
Yeah.
What's your best guess?
Percentage-wise or the reasons?
Any way you want to answer.
There is a behavioral health access study, the state study done through the Health Endowment, created by Alterum. And it has the percentages, both the percentages and some of the reasons why people say they don't access services in that report. And what we see for kind of our area is there's about I think it was a 20% unmet need in mental health services. And that's really Ingham County focused, that data. It's probably percentage-wise, I mean, numbers-wise, it would be lower in Eden County, but percentage-wise, it could be higher because there's just less mental health resources in the county. And it's huge, and that's not bad, 20% for the state. But in substance use disorder, it's more like 80%. So that is still continues to be the underserved kind of area. And some of the reasons people give, and it is different for SUD, it looks like it, than for mental health, but some of it is really related to stigma. They don't want people to know. They don't know the resources. They can't afford the co-pays. They don't think, they don't feel ready. And on SUD, because we know those defense mechanisms are so strong, what shows up on there a little more high is that they don't think they need it yet, or they're not ready yet, is a little more higher.
That's, in one way, I'm a little shocked, but, it's worst-case scenario, okay? I just get a little upset when the general public sees some people that need help, and they said, the first thing is, get the police, lock them up. Well, that isn't exactly what they need. That may solve the problem for your thoughts, but for the individuals, no, this isn't what we need. So thank you very much, Sarah. I appreciate it.
Yeah, and one of the sort of unintended, or not even unintended, one of the surprising benefits of the pandemic, I guess, was that, if there were any benefits at all, was that it really has made people more aware and sensitive to behavioral health needs. And so we have seen a little bit of a reduction in that stigma around being willing to talk about it, to ask for help, to seek services. But I don't think that that we can ever stop working on that. That's still a huge factor, and really even bigger around substance use disorder, and a lot because of some of those kinds of attitudes and thoughts.
Anything? Yep, go ahead, Blake.
Sarah, could you expand a little bit on the use of a psychiatrist at the Eaton County Jail facility? I assume it's Zoom only, and give us a little context on that.
Yeah, they're focusing on inmates who may be violent, disruptive, serious charges, which might preclude them from being seen safely in the community. So while they're there, we're able to do telehealth to meet those needs. And this was something that we'd been working towards at least a couple of years to find someone. And so we were just able to put that into place over the last, I think it was 6 months or so.
Well, and I assume that often a judge might have a request to have someone evaluated to some degree. Would this be the psychiatrist that does that, or is there a third party? Not that you know the real fundamentals, but I know those things go hand in hand.
Yeah, I think so we do have, also have a mental health therapist who does assessments in the jail. And I think in part it's that mental health therapist and the jail personnel that help to identify those who would benefit from that psychiatric evaluation.
Very good. Any other questions for Sarah? Well, thank you so much for your report. As always, lots of information, and we thank you for everything you do.
Thank you.
Thank you.
That brings us to our standing monthly item of strategic plan for substance use and misuse update. Anything there?
We are still moving forward. We are into the planning phase with MSU for the surveys that are going out. So I'm not sure if the surveys have gone out yet or not. No, Logan's saying no, they have not. So we are still moving forward in that endeavor, so.
Very good. Thank you. And that brings us to miscellaneous. Anything on your end? Okay, I will mention, just chatting up here, week leading up, it does look like we'll probably cancel the April meeting. I believe Martha was supposed to be here. She would like to go push till May. I would not be present anyway, off to a spring break trip, so it does appear to be appropriate to cancel the April meeting, so we will be back here in May. That brings us to limited public comment. Logan's looking away, avoiding eye contact. All right, good deal. Okay, good deal. All right, none there. We are, oh, yes, go ahead.
I got a question. I'm not sure whether Connie or Claudine can answer this, but on the state tax marijuana disbursements, are we participating in that or not?
We don't get very much money. It's very limited because we don't have dispensaries within the county.
Because I know Delta does not, because they have nothing.
Yeah.
I was just wondering if the county gets,
The only thing that we're receiving is money from medical, and that is small. I'd have to look it up, but it was less than 50,000, I believe,
okay, thank
we
you.
received. Mhm.
Very good. All right, we stand adjourned. Thank you.